So, welcome all for today's Gurukul Pathshala, our new episode for this month. The first episode, we always go for the OSCE. So, this month, the system we are going to learn is respiratory system. And for respiratory system, we have the OSCE today by our own Baldev Prajapati sir. Today, I'm welcoming our President, Dr. Jhankhana Sanghavi Madam, in her absentia. She is having another meeting. So if she is free, she will be joining soon. With this, I'm handing over this platform to Lata for introduction and further proceedings. She is the Chief Project Coordinator for eGurukul.
Thank you, ma'am. Good evening, everyone. Baldev sir needs no introduction. So he's the pioneer of pediatric education in our country and abroad also. So, sir, without wasting any time, we'll straight away move to sir. Sir, platform is all yours.
Thank you very much. Good evening, friends. I hope that the issue of the link is sorted out and many more students, people can join us. Let me start straight away sharing this, my PPT. Is it seen?
Yes, sir.
Now is it full screen?
Yes, sir.
Yes, sir.
Okay. So today we are going to take the OSCEs on respiratory system on pulmonology. Let me start first OSCE. In OSCE, you should be very attentive because the information is drafted very attentively because each point is important. A 2-year-old child, boy, presented with persistent high-grade fever, cough and breathlessness following measles. Not responding to oral amoxiclaviric acid. His HB was 9.6, total count 31,300, 81% polymorphs, platelets more than 10 lakhs. His chest X-ray showed right lower pneumonia as shown below. Injection subtractor was started. Patient was deteriorating very fast. And his repeat CVC after this deterioration, HP was 9.4, total count now 3,600. Polymorph 40%, lymphocyte 56%. Repeat chest X-ray showed some complication. And this is actually the repeat X-ray and CT thorax. Pictures are shown below. I give you seconds to concentrate over the pictures. Then we'll go for the questions. I hope that everybody has noted the CT scan and X-ray pictures. What are the X-ray chest findings? X-ray chest findings. Lata, if you get any response,
Yes, sir,
you can convey.
Sure, sir.
Anybody?
No, sir.
I think still they are adjusting themselves. Anyway, let me go to the answer. We know that it's a right mid zone, lower zone opacity, suggesting pneumonia. Very simple.
Sir, one participant is asking to see the X-ray again.
X-ray.
Yes, okay, let us go. Okay. So here I have put the answer of the first question. We know that very simply builds on lowers an opacity suggesting pneumonia. What are the findings of the CT thorax? What are the findings of CT thorax? If somebody wants to see again, I can show that these are the pictures of CT thorax. What do you see? Focusing this way that pathology is in right or left or both sides. Then whatever side you decide, then what is pathology? I think that's the way that how one should think. And then what is its interpretation? Any response?
No, sir. Just waiting.
Should I go for the answer?
Yes, I think so.
You know, if you focus, that pathology is on the right side, as even the X-ray shows. And findings with the multiple air-filled spaces. That is suggesting pneumonia with necrosis of the lung tissues. And that is replaced by air-filled cavity. Ideally, it should support only pneumonia. It should be just opacity because alveoli are occupied by the exudation. But with that destruction, it is replaced by air-filled cavities. And therefore, it is a necrotizing pneumonia. Already, what is probable diagnosis I have revealed? It is a necrotizing pneumonia. Then the next question, what are the most common organisms in such cases? Because
So one answer has come.
Yes.
Staph aureus.
Okay. I think rather than I would put it what is most common organism, but somebody says what are the most common organisms? One is the staph. Okay, yes, right. That means which organisms are known to cause the necrotizing pneumonia, destruction of the lung tissues and complications. It may result even in lung abscess also. Any other organism?
No, sir. Only one has to keep in.
Anyway, please keep in mind, most common is staphylococcal 100%. Most of the times it is most common. But even Klebsiella is also known to cause this necrotizing pneumonia. Even nowadays, Acinetobacter. Reason is, we are finding the difficulty in management. So we should know the organisms. Next question, what should be the line of treatment? Now we know that the 2-year-old child, pneumonia with complication of necrotizing pneumonia, these are the possible organisms. Most probably you can consider the staphylococcal, which is most common. Then what should be the line of treatment? Any response?
Just waiting. Yes, sir. What response? Amoxiclav, clindamycin.
Okay. You know that another thing always we'll have to keep in mind that now this is not a simple pneumonia. This is complicated pneumonia. Community acquired uncomplicated pneumonia, if somebody, I would say most preferable antibiotic is amoxicillin. Somebody goes amoxicillin, okay. But once the patient presents with a complication, then probably amoxicillin is not going to work. And already it is mentioned over here that amoxicillin was given. If you see this case scenario, that fever, cough, breathlessness following measles, not responding to oral amoxicillin acid. Already it is tried.
Excuse me, sir. We have few more responses.
Yes. What
1% will piptas plus clindamycin, and 4 answers as vancomycin, and one person has answered ceftriaxone with clindamycin.
Okay, fine. I think before I answer, what I want to convey, even in the practice also, that first always target the organism. You should have the answer that which organism is likely. Here, we will not be able to prove by culture also. Because in pneumonia, culture yield only 10 to 15%. So usually we don't go even for the culture, and somebody goes even with the culture, yield is very poor, only 15%. So here we have to go with prediction of the organism with the epidemiology. That age of the patient is 2 years following measles. Already the very important clue is given. Following measles, most common organism for pneumonia is Staphylococcus. So here you target the anti-staphylococcal antibiotic. Second thing, only antibiotic may not work in the necrotizing pneumonia. So it requires even the surgical intervention. Surgical intervention is very, very important. It's a good thing that most of the people have answered the clindamycin also. And what is the explanation for clindamycin? Let me go with the response. So antibiotics and surgical intervention like video-assisted thoracoscopy, and which antibiotics? Here MRSA is most common organism, even community acquired. And leukopenia indicates liberating PVL toxin, pentovalentine leukocidine, the toxin. And this toxin is responsible for the necrosis, necrotizing pneumonia. You will have to block it. And to block this toxin, clindamycin is good answer. Second thing, MRSA, with this complicated pneumonia, anti-staph choice is vancomycin. Therefore, we'll go our combination. Suppose by chance if the patient has not gone for the necrotizing, probably only vancomycin in a case of MRSA may be sufficient. But very clear cut, what is the evidence of the PVL toxin? Anybody can answer me? That from which point you predicted that there is the complication by the PVL toxin? There was some important clue in the I will say scenario. Anybody, Lata?
No, sir. No, sir. No, sir.
So here, that's the point. We are not here just one picture and question answer. We have to understand, and OSCE can be of any questions can come. What I have framed this question, some another examiner, but if you are knowing the subject and topic, you can answer it very appropriate. That's why I have selected that I will cover the topic with few questions. You know that with the staphylococcal, initially there will be always leukocytosis. So 31,000 count, polymorphonuclear reaction. Such a patient, when the patient is deteriorating and the count is going down, that's the indicate that now it is the complication by PVL toxin. Pentovalentine leukocidine. What is leukocidine? It causes the lysis of the leukocytes, particularly the neutrophils, and therefore the count goes down. That is very important clue that this patient has the complication due to this PVL toxin, and it requires addition of clindamycin so that toxin can be blocked. And meanwhile, for the surgical intervention is also required. Better to go here with the video. That's what we see, video-assisted thoracoscopy, and with this, I'm sure the patient is going to improve. So this was the idea. With this idea to cover all these points which I thought, which is very important in these, I will say, exams, any exam, maybe the X-ray, maybe even some patient, and very important even in the practice. That's why I will say piperacillin tazobactam should be given in this patient. It is not going to work at all. Because piperacillin tazobactam is a gram-negative covering antibiotic. Particularly, it is very important for Pseudomonas. So that's why I'm telling you, we should have the good explanation, prediction, and therefore, please, I'm sure that if you attend these few slides, it will be very useful in the exam as well as in daily practice. Therefore, I've selected some of the information on this topic. Please remember the very basics. If you see the gram-positive cocci, that can be staph, can be the streptococci. What the microbiologists classify that if the catalase test is positive, that is staph. If the catalase test is negative, that is streptococcal. Now in this staphylococcal, if there is a coagulase positive, we say staphylococcal aureus. And all of you know that once the test is negative, what we say cons, coagulase negative staph. Further, even if you go for no biosyn susceptibility, if it is not susceptible to no biosyn, we say staphylococcal saprophyticus. Any positive, that is staphylococcal epidermidis, hemolyticus, hominis, and these organisms are present in the skin. Many times these organisms are responsible for problems in newborns or immunocompromised. So I think if you are knowing even the organism exactly, that how we derive even the subtypes. Further, if you broadly, I think very important information, please remember for understanding, staph is the aerobic gram-positive cocci. In the microscope, they are seen in pairs and clusters. And therefore, how the name is derived, the staphylo, in the Greek, staphylo means bunch of grapes. So their appearance is like the bunch of grapes. Please remember, staph is everywhere, ubiquitous. On your table, on your statho, on your mobile, everywhere. And therefore very common. I may not go in all the toxins, but I'm sure that if you are knowing these toxins, even it will be more competent to manage every patient with the staph. Catalase inactivates the hydrogen peroxide and promotes the intracellular survival. Therefore, difficult to treat them. Some hemolysis are there, and therefore it causes even the tissue necrosis, even hemolysis, and the various beta hemolysin, delta hemolysin name is given. Coagulase cause the plasma to clot by interfering with the fibrinogen and may have an important role in abscess formation. Therefore, staph is very commonly one abscess we get it. And clumping factor creates a problem with the phagocytosis. Biofilm, suppose even the shunt is there or something, they make it the biofilm so that lose the polysaccharide capsule and interferes with the absorption of phagocytosis. Even many drugs are not reaching. So these toxins are very, and if you have the understanding, I think your choice of the drug will be very appropriate. I may not go in all the toxin, but please remember which I was talking, pentan, valentine, leucocidine, PVR toxin, which I was talking. It's a protein that Staphylococcal aureus combines with phospholipid in the leukocyte cell membrane, producing increased permeability and death of the cell. Therefore, there is drop of the leukocytes. In short, it causes the lysis of the leukocytes. And more severe disease like pneumonia, osteomyelitis, the invasive skin infections. We know that the exotoxins, it has the exotoxins also, which particular, even this can be OSCE with the staphylococcal scarlet skin syndrome. That which type the toxin is responsible. Then exfoliant A and B causing the bullous impetigo, staphylococcal scarlet skin syndrome, staph scarlet fever even. So that is, all these are the manifestations of staph by exotoxins. Enterotoxin, you know that even it can cause the food poisoning also. So it has the exotoxin, enterotoxin, even toxic shock syndrome, toxin 1. That what we say super antigen. and it can cause toxic shock syndrome with the production of interleukin-1 and tumor necrosis factor, and patient will be in shock with hypotension, fever, and multisystem involvement. I have seen even the toxic shock syndrome, multiple patients. So all these toxins, if you are knowing that how this problem or complication has developed in the patient, that will help us for the management. Now, even staph aureus is the most common, and you know how it causes the multiple diseases, if you see. Suppose if it is localizing strain, then it can cause bacteremia and the disseminated infection, which can cause pneumonia, osteomyelitis, meningitis, anything. Enterotoxin, food poisoning, already we discussed. Then focal infection, boil, abscess, sinusitis. Toxin, particularly toxic shock syndrome, toxin 1, what we say super antigen, will cause toxic shock syndrome. And exfoliating, that is exotoxin, will cause staphylococcus scarlet skin syndrome, scarlet fever, and bullous impetigo. So when you are knowing this particular presentation of the patient, you know which toxin and which drug should be given. These are the risk factors where staph infection can come on. Disruption in intestine. Child is playing in the, I will say, playground. There is just abrasion over knee, but with the entry of the staph, this patient can present later on with this staph toxic shock syndrome. We know that the eczema, epidermolysis bullosa, burns, ventriculoperitoneal shunt, indwelling any catheter, if you are in the central line and the patient has the problem, you should keep in mind severe acute malnutrition. Cystic fibrosis, 3 organisms are very common. When you are giving the antibiotic, you should know. One is the staphylococcal, another is the pseudomonas, and third one is the Burkholderia. Job syndrome, all of us know, hyperimmunoglobulin E syndrome. Staph is the most common organism. Steroid treatment, Shadia-Kegasu syndrome, post-measles staph is common. Even neutropenia can give rise to the staph, chronic granulomatous disease, and even the staph-resistant antibiotics. What are the diseases? Newborn, most common the staph, even the infection. Skin, impetigo contagiosa, bullous impetigo, cellulitis, folliculitis, furuncle, carbuncle, paronychia, staphylococcal scarlet skin syndrome. Respiratory otitis media, sinusitis, suppurative peritonitis, pneumonia already which we discussed. It can cause empyema, pneumococci, pneumothorax, even the bronchopleural fistula, sepsis, pyomyositis, and multiple abscesses. Even the bones and joint osteomyelitis, septic arthritis, very common in the newborn. Meningitis is uncommon by this time. But shunt is there, yes, endocarditis. Even the endocarditis, myocardial abscess, pericarditis, renal perinephric abscess, liver abscess, staph is most common, and toxic shock syndrome. Please, friends, pay the attention to these 2 slides for the drugs, antibiotics. In the culture, suppose if you have got, or even a community account, if you have considered methicillin sensitive Staphylococcus aureus, the drug should be cloxacillin. Orally, if you want to go cephalexin, cipadroxil, or even cefazolin injectable. I may not go into all details, but this is for the doses and uses. Cephalexin for, I will just suppose some skin infection or something, pyoderma, bullous impetigo, I will use a cephalexin or cipadroxil. Cefazolin is also very good anti-staphylococcal in injection, particularly bone infections. Please remember MRSA. Drug is the vancomycin. This is even the, vancomycin drug can be put in the OSCE and they can ask the question. It is a glycopeptide. It is bactericidal. Even vancomycin is also useful in drug-resistant streptococcal infection. Dose, 50 milligram every 6 hours IV. If it is given rapidly, occasionally you must have come across in the round that the child has the red band syndrome. Phlebitis and necrotoxicity is also very important. Vancomycin is useful for serious bacteremia, endocarditis, meningitis, brain abscess, liver abscess, peritonitis, osteomyelitis, and septic arthritis. Teicoplanin is somehow not we are using much, but it is a very good drug. Bactericidal. Compared to vancomycin, it is even the lesser toxicity. Linezolide, please keep it very specific. And it is for the MDR TB. Therefore, don't use in the routine infections. Dose and everything you know. Even very serious problems in the ICU, if you say the problem, daptomycin and this type of the drugs can be used. So this is very important. Even for common skin infections or other, you can go for clindamycin, cotrimazole, tetracycline, quinolone. They are also anti-staph. Somebody may ask the full, even the short note, anti-staphylococcal antibiotics. PVL toxin, as I was talking, very important with skin and soft tissue, pneumonia, particularly community acquired, MSSA. Please remember here, if you want to treat the MSSA, by chance if you have got even the culture positive, from vancomycin, I will go to the cloxamycin. Because for MSSA, vancomycin is inferior to the cloxacillin. Apparently looks vancomycin is higher antibiotic compared to cloxacillin, but no, for MSSA, it is inferior. Please take note of it. And clindamycin is very useful to block the toxins. D test should be done for inducible resistance to clindamycin. And linezolide can suppress a toxin produced by both staph and even the streptococcal. Therefore, toxic shock syndrome, somebody wants to treat with the linezolide, it is not, I will say, bad choice. It's a good thing. So these are the few points I'm sure going to be useful in the practice. And if you have these points in mind, your choice, everything will be very appropriate. And I'm sure it will be beneficial to the patient. Let us go to the next OSCE. I thought that it will be a little bit, may take some time, but I thought that it would be useful. Anyway, this OSCE was, I think, few years back in the exam. A 2-day-old female infant was brought with complaints of difficulty in breathing and bluish discoloration of lips and nails while taking the breastfeeding. On discontinuation of breastfeeding and crying, the baby becomes pink with normal breathing, and her CT scan of upper airway is shown over here. What is the diagnosis?
We have few answers already. Corner attrition.
Please, if you write only coronal atresia, it will be wrong answer. That's what I'm telling you. In the exam, you know, OSCE is like that. If I write, I will say you are not totally wrong. But they will not give the mark. That is very certain. So what you should write down?
Bilateral.
Bilateral coronal atresia. Because, you know, unilateral coronal atresia, the patient is not going to present in this way. Even unilateral coronal atresia will be missed by everybody. Because with one nostril, child can breathe very appropriately. Unless one side is coronal atresia and other side develops some problem, nasal block, foreign body, then that may present with a serious presentation. So here diagnosis is bilateral coronal atresia. What will you do the bedside suspicions of this condition? And what examination may directly show the pathology? Bedside, what will you do? And then how will you confirm?
So we have one answer. NG passage at bedside.
Sorry?
Nasogastric tube passage at bedside.
Okay. Good answer.
IFT not passed. Second answer.
Okay.
Infant feeding tube not passed.
Yeah, I think first answer is passing the thumb catheter to each nostril. Where will be possible beyond 3 centimeters in esophagus. And ENT surgeon can see the fiber optic rhinoscopy. And it will show the atretic plate. We may not go here now the dye study, which we were doing the dye study. Now it is not required because fiber optic rhinoscopy and it can be damn sure and even the CT scan as it is shown in this picture. What other conditions are known to be associated with this disorder? Already answer is there. Very uncommon condition, but please keep in mind what is the very charged syndrome with various defects, Treacher-Collins syndrome. The Batten is also known with the vertebral defects and even the congenital heart disease and all the things. So thus, in the OSCE, these of the questions will be there. One more. A 7-year-old boy presented with complaints of swelling and pain on right lower eyelid and mild fever. You also had complaint of blood-stained nasal discharge on the right side. An X-ray of nose and paranasal sinuses is shown over here. We can see that the 7-year-old boy problem is on right side, and even the blood-stained nasal discharge, and these are the X-rays. What is the diagnosis?
So one answer, foreign body in nose.
Yes, very good. A radiopaque foreign body seen in the right nostril. And you can make the comment, it is rounded in shape, so maybe small coin, but I think compared to coin, it is large, it is small. And a button cell. In this patient, I got it, and it was removed as a button cell. But the question may come in this way, what are the common causes of unilateral blood-stained nasal discharge? Somehow it comes with the answer also. Please remember, this is very important. Unilateral blood-stained nasal discharge. Foreign body, even nasal diphtheria, congenital syphilis, occasionally epistaxis from little cilia. What is the diagnosis of present case? Already I think it is there. By right nasal radiopaque foreign body. Okay. What should be line of treatment? I think quite obvious. It is removed. Please don't, we should not try. Somehow suppose somebody is asking me the patient, I will not do because I am not trained. Somebody is trained, okay, or best trained, because if you try, it is possible that it may slip inside and may go in the trachea and may create an emergency in the foreign body. Further, 5-day-old male neonate was brought with complaints of difficulty breathing while taking breastfeeding and becoming blue. Once he stopped to take the breastfeeding and cried, he turns pale. There was no tachypnea, no chest retraction, or any sound. Clinically normal. What is the diagnosis? What is the diagnosis?
One answer, bilateral corneal atresia.
Very good. I thought that they may put something else because immediately same. But yes, occasionally it happens so. Bilateral corneal atresia. I don't remember exact condition. It was not bilateral corneal atresia, but in one exam, different scenario, but the same condition was asked in one particular exam of the OSCE. Therefore, I thought that let me go for this condition. What are the other anomalies? Already we have discussed. What are the diagnostic investigations? That also we have discussed. Line of treatment we have discussed. Now, very important. A 2.5-year-old boy presented with cough for almost 10 months. Age is 2.5 and cough is since 10 months. He also had mild fever off and on. There was no weight loss or history of tuberculous contact. CBC was performed multiple times and found within normal limits. And this was the chest X-ray. What does this X-ray shows? I think first, rather than putting the diagnosis, you should describe it, and then you can put the possibilities.
So waiting for the answers.
Okay. No answer.
No, sir.
I think very simple X-ray is there.
So one answer has come. Consolidation of right upper lobe.
Okay.
Then one person has answered right upper lobe homogeneous opacification, CPAM.
Okay. Good try. If I answer the response to the next person, it's a good answer. Please say right side homogeneous opacity. Somebody say pneumonia. I think pneumonia we are expecting that some air structures will be seen, streak of airs, because the pathology is the lung parenchyma. Airway will be clear, so air bronchogram will be seen. Here air bronchogram is absent, so does not favor the pneumonia. And difference, I will say pathology, yes, but again, second, this is not the common site, but yes, it can happen. Anyway, let me put the another X-ray. Now, what is the interpretation of this X-ray? What type of X-ray is taken, and then what is the interpretation? I remember long back, almost 15, 20 years back, this patient was referred to me from wherever. All these multiple times, even the sonography and everything was pneumonia, the antibiotic, even the AKT, everything was given. Yes, Lata, what is the response?
So we had two more answers in between. Aspiration and collapse of right upper lung are suggestive of foreign body.
Okay. Only one response or some other responses are there?
No, sir, no more responses. I'm still waiting. One more response, abdominal TB.
Abdominal TB.
Yes.
Why abdomen? I am not sure. I think in this, what type of this second X-ray is there? On the, I will say, right hand side of my sides. What type of the X-ray picture is taken? What do you call it? That is the thing which I want. And hardly, this condition was diagnosed by me only from this X-ray.
Right lateral view, one answer.
Okay. That's good, lateral view. Then the lateral view, what you are able to see. Try to see this anatomy of that opacity. Where does it located? Where is it located?
The posterior lobe people have answered, showing upper posterior lobe opacity.
Very good. Don't say I will say opacity or posterior lobe. Lobe we don't know. Anyway, therefore this is interesting, and purposefully I brought in even these type of the pictures are seen. I think Lata, if you have not planned, sometime we can plan this OSCE on radiology.
Yes, sir, we can.
Because radiology is commonly asked everyone, and I'm sure that every OSCE, one or two X-rays are always there.
Yes, sir.
So I think that is also very important. Sometime whenever you feel, and I'm sure that I have more than 300 X-rays, very, very, I would say, useful in the daily practice and exams. Anyway, let us take the questions. Already we have gone for the interpretation. X-ray chest PA view, and that show the homogeneous opacity in right upper zone. Air bronchogram is not seen, therefore no pneumonia. Lateral view of the X-ray chest shows opacity in posterior mediastinum. Now my next question, and I think that should be our thought process. In which mediastinum the shadow is seen in the lateral view? Already it is answered, and that is in posterior mediastinum. And the next question, what are the normal structures in the mediastinum in which, that means now posterior mediastinum is seen? Normally, which structures will be located in the posterior mediastinum? And then you can find out the disease. This I will say basic logic will try to answer, will be able to answer and will lead to the diagnosis. What are the normal structures in posterior mediastinum?
We have straight away one answer, neuroblastoma,
Very good.
neurovascular.
Very good. I think if you come to know even the names, if you don't mind, you can reveal the name also. That's good. That we'll appreciate them. Any more answer?
No, sir.
Okay. Let us see. Good answer. Please remember normal structures. This is the first MBBS. And if you are knowing from that, you'll be able to link. Thoracic duct is located there. Descending thoracic aorta, even the veins, sympathetic chains, spinal column, and nerve roots. Now you can think that any of these structures can give rise to the pathology. Any of these pathology should be related to one of these structures. That much we can think. And therefore, what are the possibilities with these shadows in the extra chest? Very classically, it is not vascular or something. Therefore, neuroblastoma, neurofibroma, neurileomoma, or ganglioneuroma. That means anything with the sympathetic chain. And believe me, in this patient, CT guided biopsy was done. And this patient was operated in Apollo during that time and turned out to be the ganglioneuroma. So after the 10 months of the, and why only there was a problem of cough? Because it was obstructing the airway. Friends, purposefully I have taken again few basics of our understanding. If you remember the Cunningham's volume, that this is a mediastinum, how we, mediastinum basically it's a space between the heart and lungs. And now if you see this line to this sternum of the body, and I think fourth or fifth thoracic vertebra, this is the superior mediastinum. Inferior mediastinum is again in the anterior, middle, and posterior. Now, if you remember these basics, some problem with the anterior mediastinum. If you have taken the lateral plate and it shows in the anterior, then most commonly the thymus. Thymus can be normal or abnormal with thymoma or some pathology. Lymphadenopathy can be seen. Etiology can be tuberculosis, lymphoma, leukemia, histiocytosis, thyroidius, retrosternal, teratoma can be there, cystic hygroma can be there, hemangioma can be there. So please remember, suppose if you get this type of problem, pathology, anterior mediastinum, think with this pathology. Most common thymus, thyroid, and lymphadenopathy. But yes, other structures can also play the role. But suppose it's the middle one, middle mediastinum, then lymphadenopathy, bronchopulmonary foregut malformation, which includes bronchogenic cyst, with even the SCAM, even this pulmonary sequestration, even this, I will say, middle lobe syndrome. So all these bronchopulmonary foregut malformations can present, and these conditions I have come across. I am sure that in this radiology session, I will show all the pictures, even vascular anomalies. In posterior, already we discussed something should be most common, the neurogenic tumors. So friends, what I wanted to share that if you have this understanding, that helps a lot for coming to the, even what the CT scan may not show. You can challenge with your basic understanding. Let us go further. This graph is very famous in pulmonology. probably in the last few years, from one of the studies in Africa, that what are the probable possibilities in different patterns of cough as shown in the picture. This is the cough pattern from the graph. If you see the green one, that is acute cough with delayed recovery. That means cough was acute, remained for periods and gradually going for down, decreasing, but it taking more time. Second one is, if you see the blue one cough develops, person recovers for few days, again the cough develops. That means it's a recurrent acute cough. And the red line, if you see, it is the persistent, progressively increasing. That is the non-remittent cough. And this is the intensity of the cough. This is the duration. With every pattern, what will be your possibility? Suppose acute cough decreasing, many times very common in our daily practice. Parents will say, sir, cough has decreased, but it is there, 7 days, 10 days, 2 weeks. So here, the acute cough with the delayed recovery. What is your answer? Which condition? Can you name few conditions which presents with acute cough with delayed recovery?
So one answer has come. Dr. Teja has answered post-viral cough. Medha Gopal, bronchitis post-viral, viral.
Very good.
But pertussis also.
Very good. Most common is viral upper respiratory. Every viral does not take much time. Most of the viruses, cough even subsides in 7-10 days. But adeno, respiratory syncytial virus, these viruses are taking even few weeks together. And if you are knowing, you will just explain the mother or the parents, and you will not go for unnecessary drugs, not even the antibiotics. That is the, I will say, stewardship. If you are sure regarding your diagnosis, once you ask, then now after 5 to 7 days, mother will complain of cough persistent. But if you ask, is it the same or decreasing? Then she will answer, no, sir, it is decreased, but it is there. And then we understand that otherwise child is fine, no fever, taking orally, sleeps well. Here there is no need of unnecessary, except symptomatic, you can give some antitussive. But no more drugs, no unnecessary bronchodilators, which very commonly people prescribe. So that is the purpose, that if you are knowing it. And second, with this recurrent acute cough develops for few days, recovers, again after few weeks or months even develops. That is a recurrent acute cough. And in between recovers totally fine. There is no any problem. Can you give an example? Recurrent
URTI.
Okay.
Hyperactive airway disease, asthma.
Very good. Very good. So this is the example of bronchial asthma. Hyperactive airway disease, yes. To recurrent viral, what happens? That it's a every time different pathology. So it's a different story. That's why I will say I will say OSCE, somebody you have to respond. I will say only bronchial asthma. And persistent non-remittent cough. It's a persistent. It's a non-remitting cough. More than 2 weeks.
TB, airway anomalies, GRD, anatomical malformation, pertussis.
Please remember here it is not the recurrent cough. It's a persistent non-remitting cough. In all these conditions, it will be, I will say, recurrent or something like that. Or even it will increase and then subsides, decrease something. In post-nasal drip, on the GRD, it will be like that. It is recurrent. So answer should be only one. Suppose if you have to respond only one, then what will be your answer?
It may be, sir, mixed foreign body, which can also present like this, which clear-cut mimics or resembles on X-ray like a normal bronchiovascular tree.
Okay, right.
And in such case, sir, in past, once we have submitted such patients, અને એમાંથી ઘઉંની ડુંડી પણ બહાર આવેલી. That was a cause of persistent non-remitting cough, which was very surprisingly for us.
Possible. But most of the times, also what happens in such type of the patient, foreign body, malformations even, they're present with this, if you see this graph, that it has never decreased and never even the total free from the cough. It's a progressively, persistently increasing rate line. You are right that it happens even in any malformation, foreign bodies. But foreign bodies are somewhere even somebody is treated, even remains for some time. It may not be totally cured. I agree. But then again comes recurrent pneumonia also like that. And therefore what we say it's a cause for the recurrent pneumonia. Here please remember tuberculosis. If you read the National Tuberculosis Elimination Program, or somebody may ask the question that qualify the cough for the tuberculosis, then two adjectives are very important: persistent, non-remitting cough. So I think this and this study was done in Africa, and they divided WHO and everybody, even in pulmonology, they give very much importance to this pattern of the cough. That simply just if you as a clinician go for details of pattern of the cough, most of the times you'll be right. As you said, even every time you may not be right. What I said, tuberculosis may turn out to be foreign body, you are right. But most of the times we'll be right. So that's the importance of this cough. Anyway, let us go further. 9-month-old child was referred for recurrent pneumonia, which gets resolved with the antibiotics. There was also history of recurrent vomiting. And further evaluation is shown in the picture. Even what type of investigation is done, then what does it show, what is the diagnosis, like that the questions will come. But I keep the picture for some time for your detailed study. You can see even the history also, that 9-month-old child with the recurrent, even the pneumonia, somehow it responds to the antibiotics. That means patient recovers. But again develop. That means the recurrent pneumonia. And even there was the recurrent vomiting also. And
so we have few answers. Sorry.
Yes.
Echinacea cardia, barium swallow, and GRD. Milk scan GRD, barium swallow.
Very
This
good.
much answers.
Good responses. The investigations is a barium study, esophagogram, what we say. Good. Very good. What are the findings that the paper has given? There is the gross dilatation of the esophagus with narrowing at the lower end. And very classical picture of, yes, it is the echinacea cardia. So, what are the common symptoms of this disease? Let me discuss non-bilious vomiting, because it will be the non-bilious, because it is above the second part of duodenum. But of course, with this vomiting, even the low respiratory infection, pneumonia, as already we discussed, even failure to thrive. Naturally, child is not getting sufficient nutrition. And then what is the treatment? Even the medical treatment with oral medicines are possible. Somehow commonly we are not using. I think it is more common in the adults they use it. And best way is to go for surgical management with the myotomy and anti-reflux procedure. Anyway, 2-year-old girl presents with fever, cough and fast breathing. Respiration rate is 70 per minute. The child has subcostal and intercostal intra. She is lethargic, not taking fluids. Just look at the information given, then I will give you the question. First question, what is the probable diagnosis from this? Please remember another thing, the OSCE, answer should be precise. Just if you answer, they will not consider the correct answer. So in OSCE, very important that the meticulous answer should be there. 2 years old patient with a fever, cough, fast breathing. Respiration rate 70. Indroids. Lethargic and not taking. Yes. What is the diagnosis?
Sorry, sir. Severe pneumonia according to IMNCI.
Yes,
severe pneumonia with sepsis may be an answer, and mostly people have answered severe pneumonia.
Very good. Very good. I think that's the thing. Severe pneumonia should be the answer. Only pneumonia is not the correct answer. That's why I was having the apprehension. I think here sepsis somebody has written, maybe they consider lethargic, but lethargic indicates the hypoxemia. And you were not able to take feeding, sometimes not able to speak even. It indicates the severity of the problem. And here somebody is going to ask the question, what is the cutoff value for tachypnea? So please remember, this question is going to be common in Viva also. 0 to 2 months more than 60, 2 months to 1 year more than 50, 2 to 5 years more than 40, more than 5 years more than 30. This is the cutoff value for the tachypnea. And please remember, as far as possible, respiration rate in younger children should be counted when the child is sleeping. Sleeping pulse rate is more reliable. Or suppose child is taking the breastfeeding and calm, okay, you can do it. And counting the respiration rate should be for fully 1 minute. I remember in one of the DM exams, one of the pulmonologists was talking to me that he was not considered because he didn't count the pulse rate for 1 minute. So this much importance is given. Second point which I want to, in IMCI somebody is quoted, very good, I will say point. Tachypnea is very sensitive marker for diagnosis of pneumonia. Tachypnea is very sensitive. May not be the specific. That means tachypnea can be due to some other conditions also. But not to miss. WHO and IMCI has given even to paramedical persons that with this respiration rate and even this severe pneumonia, they can differ early and the under 5 mortality rate can be brought down with controlling the acute respiratory infection control program. This is the idea. What are the signs of increased work of breathing? Please remember another thing. Actually, this with the one click, even you get the answer also. I will have to change it. But increased work of breathing, the first tachypnea, retraction at various places, subcostal, intercostal, suprasternal. That also indicates, subcostal most commonly lower respiratory infection, pneumonia, or even bronchiolitis. Intercostal, most common with the cardiac cause, CCF. Suprasternal, extrathoracic obstruction. Use of accessory muscles of respiration, sternocleidomastoid. Various sounds and wheezing, stridor and grunting. Wheezing is due to the intrathoracic obstruction. Stridor, extrathoracic obstruction. Grunting is due to the lung parenchyma problem. Highland membrane disease is a classical example. But in pneumonia, also severe pneumonia, the presence of grunting is indicating severe pneumonia. Tracheal tug, what we say, that means inward movement of trachea during respiration. Flaring of alienacy, head bobbing, and of course, with severe, when there will be the cyanosis. It's too late. But these are the signs of increased work of breathing. What is the classification of severity of this disease as per acute respiratory infection control program or even IMCI? This condition, what we say pneumonia, that means. What are the ways of classification? How we classify according to this program, pneumonia? Anybody?
The very severe pneumonia, one answer we have got.
Okay. Any other
Few
way?
people had answered severe pneumonia before.
Okay. There is the various categories what they have put forward. I'm sure that once I put the answer, they will realize that yes, it is there. First, no pneumonia. That means cough, cold, but no fast breathing. So without fast breathing, don't say, and why reason is, if you say no pneumonia, no antibiotic. That is our idea of promoting this point. Pneumonia, as I said, fast breathing, as per the criteria for tachypnea. Maybe even with indrawing or without indrawing. Severe pneumonia, already we discussed, tachypnea, lower chest indrawing, unable to drink or the breastfeed, lethargy, cyanosis, sometimes convulsion, and even the unconsciousness. So these are the features of, that means no pneumonia, pneumonia, severe pneumonia. So these are the, I will say, points of classification, categories which we should remember. Now answer the following questions based on bronchial asthma. Sometimes they put this is actually I have taken from one of the exams only. I didn't have the idea, but they put these types of questions. Explain all these short forms. And these short forms are accepted in this GINA. The GINA, that is Global Initiative for Asthma. ICS, that means inhaled corticosteroids. MART, that is maintenance and deliver therapy. ART, that is anti-inflammatory reliever therapy. And for everything, there is one protocol which we should do. What is the recent change in GINA guidelines as far as management of children between 6 and 11 years with intermittent wheezing is concerned? This is very important change, and I think everybody is discussing. In our last I think who was discussing, but Respiratory also this point was taken very nicely. I think there's Dr. Nagbhushan Rao from Bangalore. What is the change in GINA guideline? Particularly children between 6 and 11 years with intermittent wheeze.
So we have one answer. ICS used as both maintenance and deliver therapy, used in step 1 and 2 therapy also.
With answer, can you get the name?
Medha Gopal.
The reason is, I appreciate, yes. They give the ICS whenever inhaled short-acting beta agonist is given. Usually, previously, we were not doing. But now this very significant change has come. Inhaled corticosteroids. And what are the drugs used in MART therapy?
Yes, somebody has given us BP. We can use MART.
What is the rationale behind it? What is the MART? If I remind you, already we discussed, MART means maintenance and deliver therapy. Together you can see MART, maintenance and deliver. So please remember, MART therapy, that means use of inhaled steroids combination with long-acting beta-2 agonist. That is formoterol. And please remember here, only formoterol is preferred. No any other drug. That is the MART therapy. Use of the ICS along with long-acting beta-2 agonist, formoterol. And it is in the same pressurized beta-dose canister. The preparation is available. So I think that should be used. This is very important change. And other long-acting beta-2 agonists do not have the shorter time of onset of action, like formoterol. And hence, MART therapy is always only with the formoterol with inhaled corticosteroid, the same canister which I was discussing. and that preparation is available. So that is there. And what inhaler devices are recommended to use in different age groups? I think very important for practice also. Up to 3 years, the inhaler plus spacer and face mask, or even the nebulizer. Meter dose inhaler, we say PMDI. 4 to 6 years, PMDI plus, along with the spacer, face mask may or may not be used. More than 6 years, meter dose inhaler with or without spacer, or based more than 6 years, you can go dry powder inhaler. So these devices should be used appropriately according to the age of the child. This can be asked even in the table viva also. They put it, even mark therapy also, they will put the preparation and then they will start the dialogue. Question answer, viva will be started. Answer the following questions based on maintenance and deliver therapy, that is MART. These questions are on the MART. MART now they discuss very important because it is a great change. What is the composition of very low dose inhaled corticosteroid formoterol? Very low dose. That also we should know, accordingly we should use. Any response?
No, sir, waiting, sir.
Because question is difficult, I understand.
So I got one response, 200 microgram, two responses in fact, 200, Dr. Kunal Jariwala and one Zoom user.
Okay,
200 microgram.
I think Zoom user should reveal the name. Anyway, please note it. Very low dose, once you say very low dose, that means formoterol 6 microgram and inhaled corticosteroid 100 microgram. Mostly commonly we use the midazolam, but even beclomethasone can be. But I will say commonly in the practice it is available and we use it, formoterol and midazolam combination. Once you say very low, that means formoterol 6 microgram and midazolam 100 microgram. So that is very low. Similarly, what is the composition of low dose inhaled corticosteroid formoterol? I said first very low. Now it is low. Very low, that means 6 microgram and 100 microgram. Low means formoterol 6, but steroid we increase to 200 microgram.
200, yes. 1% answer.
Yeah. And maximum dose formoterol in the adolescents when used as a reliever. Please remember, in MART, reliever in adolescent, maximum 12 doses per day. Numbers of doses, 12 doses per day. I think this is very important and probably very commonly people may ask in our table, viva, so many other places. What is the maximum dose of ICS formoterol in children 6 to 11 years when used as a reliever? Maximum dose? Anybody?
Waiting for the response.
Please remember, reliever in children 6 to 11, maximum 8 doses per year. Adolescents, you can go 12 doses per day. But in 6 to 11 years, 8 doses per day. I think this is very important and very prominent changes are there. Anyway, now one more question. Name and elaborate components of scoring system for acute tonsillitis. For acute tonsillitis, scoring system is there. At least if you name that also probably you'll be able to remember. Very commonly used. Any response? Any name is there?
No, sir. No, sir. Waiting for this. So one answer has come. It is not. 8 was discharge alternate swelling.
At least if you remember the name, I think you can put the name. The name of this scoring system.
Back ISAC score.
Please remember this one. This is called the center criteria or center score. And age is 3 to 14 years, 1 point. Every criteria has 1 point. Tonsillar swelling or exudate, tender or swollen anterior cervical lymph node, fever significant 100.4, and no cough. Please remember, this is very important, absence of cough. In tonsillitis, cough is not the problem. When cough is there, it is viral. Even with the tonsillar, I would say swelling also. This is for the, I would say, antimicrobial stewardship rationality. This is very important. If you use this one, automatically there will be the cutoff of the antibiotics. And in the center score assess the likelihood of possibility of streptococcus to decide whether should I go for the antibiotic or not. And they say that clinical criteria of center fever, tonsillar exudate, tender cervical lymphadenopathy, and absence of cough. And suppose the score is 3 to 4, then high probability of streptococcal, and therefore go for the antibiotic and even further investigation. But suppose the score is only even up to 2, that means bacterial infection should not be considered, low probability, and no antibiotic. So this score is given the importance, and commonly people are discussing in the exams also from this point of view, that the score is above 3, you may go for the antibiotics. But if the score is below 3, there is no need of the antibiotics, and simple criteria if you follow, in significant numbers of the patients, there will be drop of antibiotic prescription. That is the importance. I think here I will give you one, it is a actually word, but I will give the comprehensive information regarding the streptococcal infection, because again it is very common. And I'm sure that if you know, it helps a lot. Please remember again, streptococci are cocci, like staph, but they are in chains. If chains means streptococcal, and in clusters, that means streptococcal. And just information, strepto name is derived from Greek word like twisted chains. And streptococci, if you see in the microscope, they resemble the string of pearls. It is like string of pearls under the microscope. We should know that the streptococcal pneumoniae, what we say pneumococcus, is different from this streptococcus. Many times I see that it is mixed up by the people. When we say pneumococcus, it will cause the lobar pneumonia and meningitis. In pneumococci gram-positive lancet-shaped bacteria, I think if you remember, in pairs. And therefore we say with the diplococci. And for pneumococcal we have the vaccine. So that is the different pneumococcal. Should not be mixed up. It is called the streptococcal pneumonia, which should not be confused. Streptococci are the part of normal flora, aerobic faculty okay. I think particularly important how they are classified according to hemolysis. Alpha hemolytic streptococci cause partial hemolysis of sheep armiasis. So partial hemolysis, alpha hemolytic. Greenish discoloration, and therefore we call them the streptococcal viridans. Viridans means green. These are normal, but streptococcal viridans is the organism for bacterial endocarditis. Beta hemolytic streptococci will cause the complete hemolysis. And gamma are non-hemolytic. Again, please remember the beta hemolytic streptococci They are grouped under the polysaccharide. What we say, Lensipid C, that is Lensipid classification. And Lensipid classification of beta hemolytic streptococci. More than 20 serology groups, and according to the A, B, C, like that they are given. But A and D are important from our disease point of view. Various enzymes are there that you know, and group A streptococci can be subdivided in many serotypes. But I think this is important for us to know. These are the various diseases, just for your information, pyogenes and even other organisms. I may not go into the details. Very important, please remember for rheumatic fever. You know this, why we discuss so much for the tonsillitis and streptococcal infection? Because if you don't treat, then also they recover. But late complication, immunological complication, like rheumatic fever and streptococcal glomerulonephritis are common. These are the strains. I may not go into the details, plus it better you keep in mind. These are the common streptococcal infections. Again, better to know. Even chorea is also considered due to that. Pandas also there. Even streptococcal reactive arthritis, toxic shock syndrome. Nelson has given the very good table. Following even the varicella or chickenpox, necrotizing fasciitis is due to this fear. So that we should do. Anyway, I think now we can take one or more and then we can end over here. A 6-year-old girl was brought with complaints of fever and persistent cough of 4 weeks duration. Mother also noted the loss of weight. The father is on anti-tubercular drugs for 4 months for pulmonary tuberculosis. This is the information. Now the questions. What is our presumptive diagnosis? Any response?
Yes, pulmonary tuberculosis. One DP has answered. Then Medha Gopal, pulmonary tuberculosis. Pulmonary. Everybody is answering pulmonary tuberculosis always.
Okay. Good answer. What are the points for presumptive? I think immediately answers are also come, but suppose if I remove it. What are the points for considering the presumptive diagnosis of tuberculosis? You know, for tuberculosis now, presumptive, probable, and confirmed. What are the points for to label that it is a case of presumptive tuberculosis? What are the points? If I remind you, there are 3 points.
So we have few answers.
What are the answers?
The DP has answered persistent cough and fever more than 2 weeks. Weight loss. Father is known case with ATT. Nehal sir has answered fever, persistent cough, and weight loss.
You know, here presumptive diagnosis. So exactly and that's why I said 3 points. Very rightly, I think answer. You know, regarding fever, please remember the adjectives. 2 weeks fever can be even anytime different reasons. But here, persistent, documented fever of more than 2 weeks without a known cause. That means no any other cause is there. No upper respiratory, no urinary complaint, no bronchitis, and there is fever is persistent, documented fever for more than 2 weeks duration without a known cause. Cough already we discussed from that graph. It's an unremittent cough, persistent cough for more than 2 weeks. For weight loss, please remember that this question is going to be there in your long case also of any CNS, tuberculosis or something. Just weight loss is not the answer. How you define it, that is very important. And it is defined as more than 5% weight loss compared to optimum or highest recorded in last 3 months despite adequate nutrition. Or even failure to gain the weight in the last 3 months is also weight loss. So please remember, as per National Tuberculosis Elimination Program 2022, they are very precise now. I think we can keep even one OSCE totally on tuberculosis. I have more than 100 questions and very, very frequently asked even in your Viva and everywhere. I think in my book on the essential for PG exams, I have given the more than 100 questions on this tuberculosis and very precise answer. One more. What is tuberculous contact? We have to define it very appropriately. What is tuberculous contact? How will you define the tuberculous contact? Again, this is going to be the question in your Viva, in your case discussion. Even whoever is the examiner, they are going to ask you.
So we have one answer, second answer. Contact within past 2 years, last 2 years, then contact within last 2 years. Everybody is answering like that.
Okay, good. Please remember, tuberculous contact is defined as contact with a person with any form of active tuberculosis. Again, this is very important. Now, pulmonary, close contact, all the things which were there, they are removed. That person with any form of active tuberculosis within last 2 years. Your active tuberculosis may be in the form of the anywhere, not necessarily pulmonary, but they say that likely associated with pulmonary also. So this is the tuberculous contact definition now. And then what initial specific investigations would you perform in this case? Suppose this is the presumption of tuberculosis. Now you have fairly good background. The documented fever is there more than 2 weeks. Unremitted cough is there. Weight loss documented. Somebody suffering already, here it is noted, father is on drug. That means every scenario is given. Now, what is suppose if you have to go for only one investigation, first one investigation, which one you will do? I will ask the question in this way. Only one. Now with this information, you have come to the conclusion with cough, fever, contact, everything, that tuberculosis is highly presumptive. One investigation, only one.
So we have divided opinions. Medha Gopal has suggested chest X-ray, DP chest X-ray, Nehal sir, Chintu, DP, and Dr. Josefa, CBNAT, and Motorola Moto sputum CBNAT.
Whom should I consider? Please, if you see the National Tuberculosis Elimination Program, I think you said Megha Gopal or something you named?
Medha Gopal.
Megha Gopal.
Medha Gopal, yeah. Chest X-ray.
I think from which institution she is there? Megha, can you put it? Megha will put herself, I will say, from which place and which institution?
Dr. Medha Gopal, please tell from which institution you are.
Yeah.
Sir, AIMS Devghar. AIMS Devghar.
AIMS?
Devghar, Jharkhand.
Jharkhand, oh, very good, very good. Well, I'm coming to the point that her responses are genuine. Please, if you see the National Tuberculosis Elimination Program, the first investigation should be chest X-ray. Of course, I will say CBNAT and others are not wrong, but the first should be the chest X-ray. Now my question is, these X-rays, and please try to read every X-ray. That suppose what does this X-ray do? I will say, I'll take the answer one by one. I think you are able to see my cursor is moving. Left hand upper I will say first X-ray upper corner. What does it show? And then say whether does it suggest tuberculosis, favoring tuberculosis, yes or no. Let us take, I will say one by one, because even this may be the X-ray in your exam also. Any response, Lata?
No, sir, we're just waiting.
I ask only for this X-ray, please. Left hand side, upper corner. In any, if I ask direct question, does it indicate tuberculosis?
So we got two responses. Sherina told hyalid lymphadenopathy. Dicky
Where?
no TB. Medha Gopal no.
What they say?
Two people said no tuberculosis. Who said it is hyalid lymph node.
Where? Which side? You know,
Side
purposefully, these people have put the
left.
X-ray. Yes, if you see here, I think I may not be that technically good person, but I'm sure. Are you able to see my cursor over here? Lata, are you able to see?
Yes, I am able to see.
Yeah. You know, this here we are expecting concavity. If you remember this normal X-ray, but the fullness indicates left hilar. And please remember, right hilar shadow is non-specific. But if left hilar, and with this scenario, suppose this suggesting presented tuberculosis, it is suggesting. Anyway, middle one. Middle one, what does it show? What does it show? Tuberculosis point of view, I'm asking. So this X-ray is of some child or person with the suspicious or presumption of tuberculosis, and this X-ray is there. Middle one. Any response?
Yes, so just now I got a response by Medha Gopal. Is that not thymus shadow? That she's asking actually.
Sorry, what did she say?
So she's asking that is that not thymus shadow?
So she's asking question or replying?
She's asking question. Mehul sir has said it's superimposed shadow, looks like thymus.
You know, if you see, I think here that these shadows on both sides, right and left, and they are more of the rounded shadow. Thymus will not be the rounded shadow. So this is again the paratracheal glands. And here also the right paratracheal gland is same. What this X-ray shows? This particular X-ray, left side lower one. I hope you are able to appreciate in the picture.
So we have few responses. Miliary TB.
Very good. Who answered miliary TB?
Miliary TB has been answered by DP, Medha Gopal, Zoom user, Sherina, Jabir.
Very good. Many people. And yes, please remember this biliary tuberculosis, the biliary shadows, the X-ray is going to be kept very common. And this one, middle picture, lower down, and even this picture.
Last is cavitation. Dr.
Yes.
Teja has answered.
This is cavity, yes. And this one? Cavitation. This one also, if you see some cavities, and even the more of these confluent opacities. Now, you know, which X-ray pictures are highly suggesting tuberculosis? Please try to answer. Which X-ray pictures, according to National Tuberculosis Elimination Program, are suggesting possibility of tuberculosis? Again, if I guide you, they have considered only 3 types of the lesions on X-ray, which are very specific for tuberculosis. Which are they?
So we have few answers. Medha Gopal has answered miliary, cavity, and hilar lymph node.
Very
Nehal
good.
sir has answered almost. TB can come as GT of all X-rays. DP has answered hilar lymph node, cavitation, miliary. That's all.
Okay, fine. I think they are right. Please remember, if you get the miliary, if you get cavitary, if you get paratracheal, particularly the paratracheal, rather than hilar, these are highly severe, and therefore we say then the probable tuberculosis. But here, even in this juncture, please remember, it is probable. We have to confirm. We have to confirm the macrobiological diagnosis. We are not allowed to start this anti-tuberculosis therapy. You can say highly suggesting yes. So that is very important from the radioimaging point of view. I think here few questions I have not put it, but somebody is going to ask you. Let me discuss 2 or 3 questions on tuberculosis. Then, on the contrary, tuberculosis itself is a very big chapter and very important. Everybody should know. What is the role of sonography for diagnosis of tuberculosis? Somebody is going to ask you the question in this way. What is the role of ultrasonography in diagnosis of tuberculosis? What are the various utility of ultrasonography for tuberculosis?
Jabir has answered to rule out pleural effusion. Nehal sir has answered to do USG guided aspiration of pleural fluid.
Good.
Dr. Teja has answered abdominal TB. DP has answered where effusion is there. Zoom user has answered in abdominal TB. Chintu has answered TB pleural effusion. Medha Gopal, sir, necrosis in lymph node. Then lymph nodal TB by Zoom user.
Very good. Also, different answers are there by different persons, but if I answer, please again remember, every time sonography is not helping. But once very specific changes are there, that you can give the importance for diagnosis of this. Number 1, suppose once you are not clear whether it is really paratracheal gland or thymus, either you go for the lateral chest X-ray or good sonologist. He can differentiate that this is thymus and not the lymph node. That is the utility of ultrasound. Number 1. Number 2, yes, for pleural effusion, collection of fluid in the pleural cavity, ultrasound is the good answer, rather than even the chest X-ray. So that is the second utility. Third, from tuberculosis point of view, tuberculosis gland point of view, if good sonologist is able to say that there is some necrosis or calcification, which they can do on sonography, then again you can say highly suggestive, probable diagnosis. And that is the good utility of the sonography. Further, under sonography monitoring, you can do either the FNAC or even you can go through pleural tapping. So these are the utility of ultrasonography in diagnosis of tuberculosis, not beyond that. I think abdominal again may not be beyond that, except some lymph nodes. And lymph nodes also, suppose mesenteric lymph nodes, suppose somebody is asking you, that mesenteric lymph nodes very common, I will say, reporting in this ultrasound abdomen. And then people unnecessarily go for tuberculosis possibility. No, it is going to be their lymph nodes, mesenteric lymph nodes, because GI infection is going to be very common in everybody's body. But for tuberculosis, if I am not wrong, regarding numbers of lymph nodes, size of the lymph node more than 10 millimeter, multiple lymph nodes, matted lymph nodes, again showing necrosis or calcification, you can say that importance from tuberculosis point of view. Just presence of lymph node is not important. So this is number 2. Third importance, similarly, how the CT scan is useful and what is the utility of CT scan for diagnosis of tuberculosis. CT scan, please. Routinely, we don't advocate the CT scan for diagnosis of tuberculosis at all. We should be very clear. But if at all, if you go, then in what way it is useful? And accordingly, you may utilize the CT scan. So please, what is the utility of the CT scan for diagnosis of tuberculosis?
Waiting for response, sir. No
Yes.
response.
What is the response?
The bronchiectasis as a complication by Ranjan.
Okay.
No more responses, sir. Still waiting.
I think it's very important. Let us wait for some time, but it is going to be quite useful. Any more?
No, sir.
Okay. Please remember, CT scan, we don't advocate for diagnosis of tuberculosis. We should be very clear. Keeping in mind due to the radiation, anyone with the less radiation, but still. But really, suppose if you suspect the malaria on an X-ray, and if you are not sure, miliary shadows can be detected very nicely by the CT scan. In that case, you can go for the CT scan. Second, again, necrotic mediastinal lymphadenopathy. Lymphadenopathy can be due to tuberculosis, can be due to lymphoma, can be even due to the histiocytosis. Therefore, but if you go for the CT scan and the lymph node is showing the necrotic lymphadenopathy, that is suggesting tuberculosis. Centrilobular pattern, centrilobular nodules, and tree in bud appearance, that is suggesting tuberculosis. Cavities surrounded by this consolidation, suggesting tuberculosis. So these are the CT shadows. And very important is CT guided biopsy. So that is very, very important, which all of us should know. I think one or two questions and then we learn, particularly macrobiological diagnosis, always go for the Zn stain. Very important, AFB may be seen. Very few patients we get it, but we should do every patient. Very important is Sibinate. Sibinate in the sputum, if older child, or induced sputum, gastric aspirate, or even the bar, whatever you get it. Or even the lymph node biopsy or any structure biopsy. And then you should go particularly for the Sabinate, what we say, or even somebody may ask the short one, WHO approved particularly rapid diagnostic test, and that is the Sabinate. What we say, I will say Sabinate, you know, that it's a molecular diagnostic test. Now Sabinate Ultra has come. And Sabinate Ultra is more sensitive compared to the Sabinate. Even if the presence of less number of the bacilli, still it can be detected. Then the TrueNet is there. True, it is different instrument that without even the electricity, it can be operated on the battery. Therefore, any remote place you can use. And then line probe assay and LAMP. They are the WHO approved. Very important that any material, if you have collected, please send for this cabinet. That is very well. Cabinet, if you get it, that is this diagnostic. Occasionally, it can be negative. So negative does not rule out, but positive, cabinet confirm the diagnosis. For culture, you should go for the MGIT. That is the liquid culture. Now it's available. So I think so many things are there in tuberculosis, but we'll have to end over here. And I'm sure that it is going to be quite useful in this discussion. I think sometime, if the time permits in your schedule, we can go for this, I will say, discussion. One is the OSCE and radiology, which is very common in all the exams, or even on tuberculosis also. So whenever I will say your schedule comes, you can just, these are few points suggested when I was discussing. I thought that may be the important. Anyway, we'll have to end over here. I hope that purpose is served. It was good that the many students were responding, and when the responses were good, I will say correct responses. Even I will appreciate that faculties like Mehul Gosai, Dr. Charul, even they are present even up to the 10:30, 11 o'clock. Naturally, Nehal and Lata is going to be there because they are organizers. For them, I will say there is no option.
No, sir, we also enjoy.
Yes, sir, we also enjoy. We also learn a lot of things.
But really, and we are happy that even the students from every corner of the country, they are attending. As Lata said that Meda Gopal or somewhat name says that she's from even the Jharkhand. So, I think that's the thing, that how all of us are learning with interacting with each other, and that's good. So thank you very much, all of you. We'll have to end over here, and next Thursday, whenever your, I will say, suggestion or order is there, I will follow. Thank you very much, and good night to all of you. Good night. Over to you, Dr. Lata and Nehal.
Thank you so much, sir. There is one announcement for all the students that for the next Thursday, we will not be having any session of e-Gurukul. We are all busy with the Vezon Pedicon, and the exams also is there for the MD students. So the many of the students are appearing for exam, they are not available. So for the benefit of both the things, we are skipping one Thursday, and then on the 20th, we will be going for the case presentation.
Fine.
So thank
Noted.
you so much. Thank you so much, sir.
Thank you, all of you, and good night.
Good night. Good night, all.
Good night.
Thank you, Lata. Thank you all.
Good night, everyone.
Good
Good
night.
night.
Good night, Charul. Good
Good
night.
night. Good night.